So today, as Christopher said, I will be basic, and it's maybe you know all this, but it's important to repeat and repeat some basic stuff because I think to measure the ventricles, to have a look at the midline, to know the maturation of the brain, just facing the Sylvian fissure and looking at the facial fissure. It's for me very important, and I think that even on Monday I will give you a short lecture about 3 difficult cases, and I think it's good for experts to see this case. Today it's the basic, but you need the basic to go to the expertise on Monday. So if you know all this, on Monday it will be simpler. So for sure, we'll speak about the ventricle and how to measure the ventricle. We'll go to the midline and see the cavum septum pellucidity. But more than that, we'll see the anterior complex. And we'll finish with the Sylvian fissure before a short life scan. So you know that we published an article in online about how to standardize this procedure about the measurements of the ventricle. Why? Because you know that in the guidelines of the ISUOG, the lateral ventricle is an important structure to look at, because ventriculomegaly is the main finding for CNS pathologies and diagnosis. And in fact, how you measure the ventricle. Most people say, yes, it's very difficult. It's easy to measure the ventricle. You have an axial plane, you look at the thalami, and it's simple. But in fact, this was published in 1988, and 2 years after that, there is this publication showing that we can be off axial plane. We can have not a good choice of the ventricular border. It can be angulated, and all this lead to false positive results. It's like the main question is, when you have a ventricle which is around around 10 millimeters, and you call this a borderline ventriculomegaly. The main issue is to know if there is ventriculomegaly or not. This illustrates in this case, this patient was referred in our lab for borderline ventriculomegaly, and we can have 10.8, 12, but if you measure accurately, we are at 9, and there is no ventriculomegaly. A good example is this zucchini. When you want to cut slices of zucchini, you can do it in orthogonal plane, and perpendicular to the zucchini. And you have this slide. But if you are off and a little bit oblique, you will get this slice, and the second one is larger than the first slide. And it's exactly the same thing. And it's why we publish this score. The important thing is to be strictly axial, to be at the good level, and to know where is the atrium. And there is a question about placement of the caliper and image size, but the 3 main criteria are the 3 first ones. The first ones, what means strict, and how can be sure that I'm strict. Your midline should be perpendicular to the ultrasound beam. This is very important. I will show you how to do that during the live scan. And when you have the midline perpendicular, this midline should be at equal distance from the proximal and distal calvareal margins. That means you are the midline is orthogonal to the beam, and D is equal to D prime. This is very important. So in that case, you have orthogonal slice, and you know the main question is at which level should we cut the zucchini? Some people say you should use the thalami. In fact, the best thing is to have 2 landmarks, one anterior and one posterior. The anterior one can be the cavum septum pellicidi, and it can be also the fornix colon. And the posterior landmark is the fluid-filled space of the ambient cisterna. This is the triangular space of the ambient cisterna, which is here. It's subarachnoid spaces. And this is either the cavum pellicidi, and here it's the fornix colon. And this is much more accurate than the thalami. If you are strict at the good level, you have to locate the atrium. How to locate the atrium? If you think about the plexus, it's very difficult, in fact, and anatomy suggests that the atrium is facing the internal parieto-occipital sulcus. That means that glomus is easy to identify, but this location will change depending on the shape of the plexus choroid and on the degree of dilatation of the ventricle. So look at the internal parieto-occipital sulcus. It's the definition of the atrium. It's depicted on the inner border of the hemisphere, and it's small depression, and it becomes deeper at the end of the pregnancy. This is here, this small depression here, and you see, you measure, but in this case, you are at the level of the plexus choroid. But here, you see, you are far away from the plexus, and you see the depression with the arrow. You are exactly at the atrium. And when you are in the third trimester, this sulcus fissure becomes deeper, and you should measure at the deepest part of the fissure. This patient was referred for amniocentesis, for ventriculomegaly, but if you look at the image, in fact, it's not orthogonal, and the sulcus is here. And in fact, it's the occipital horn. And very often, in the second part of the pregnancy, there is a sort of dilatation, slight dilatation of the occipital horn, and it could be, in fact, diagnosed as a ventriculomegaly, and it's just a variant. And if you measure carefully, in fact, there is no ventriculomegaly at all. So, how to measure and how to place the calipers? You know it's on-to-on, orthogonal to the ventricular wall, and you should have a good magnification to see the proximal and distal calvarium margins, and you should avoid excessive or low magnification. The main interest is to improve your reliability for measurements which are close to 10 millimeters, and improve also the reliability of the follow-up, especially if serial examination was performed by different operators. Let's move to the anterior complex. You know that cavum septum pellicidi is very important, and it's a good landmark to diagnose midline anomalies. Why is it this structure which has been chosen for midline analysis? Because it's easy to identify, and you should visualize these structures between 18 and 37 weeks. But in many conditions involving the midline, this CSP will be not present in holoprosencephaly, in complete agenesis of the corpus callosum, and you may also have absence of the cavum septum pellicidi when you have a severe hydrocephalus because of a bad or traumatic insult, schidencephaly because of ischemia, and you may have congenital absence of the cavum septum pellicidi, which is an agenesis, and in some cases, a few cases, related to septo-optic dysplasia. But in our casuistic, we have cases of false image of CSP. As in this case, I will show you two images. One is a false image, one is a real CSP. For sure, for you, the CSP is here. This is not the CSP, because in this case, you have a complete agenesis of the corpus callosum. And you know, sometimes there is dilatation and ascension of the third ventricle, which may mimic a CSP. So we publish in 2013 the fact that we should improve our detection and looking at the anterior complex. This is this. This is, in fact, a complex formed by the cavum septum pellucidity, which is here on sagittal view and axial view. And on each side, there is a frontal horn. It can be interesting for you if you look at the anterior complex to see that the two horns are symmetric. You know that for the ventricle measurements, it's sometimes difficult to see the proximal ventricle. If you look at the symmetry, it can be a good indicator that there is no dilatation on the ventricle, which is on the proximal hemisphere. Now, here you have the genu of the corpus callosum. You see the genu is here, and you have just above the genu the pericallosal sulcus, which is here. And this looks like an anchor. And you see the base of the anchor here is the pericallosal sulcus, and the arm of the anchor is the anterhemispheric fissure. Is it interesting to see this anterhemispheric fissure? Yes, because we report that in some cases there is a distortion of the anterior part of the anterhemispheric fissure. And in that case, it can be an indicator of midline anomalies, but also or more complex CNS anomalies. But we have 2 cases in this publication, and now we have 5 cases like that, with a very strange aspect of the anterhemispheric fissure, but with normal baby. So it's just a feature, it's not a pathology. So look at that, and if you have something which is distorted like that, think about the midline, think to see carefully and synchronize the brain, but if there is nothing else, the baby can do doing well, as in absence of the cavum septum pellucidity. So for midline analysis, look at the anterior complex, and after, to finish, the Sylvian fissure. For me, it's the most important part. I put my probe, I look at the Sylvian fissure. And the Sylvian fissure is not cited in the guidelines. But you see, on the diagram here, you see the Sylvian fissure. The fissure is here, under your eyes. So look at the Sylvian fissure. And why you have to look at the Sylvian fissure? Because from my point of view, to have a look at all the gyration is a waste of time, because there is inter-individual variation for secondary sulci, and the Sylvian fissure is very, very simple. You have this under your eyes, and look at the posterior part of the Sylvian fissure. This is the insula, this is the temporal lobe, and look at this part. At 22 weeks, it will be 45 degrees. It will be square at 24 weeks, and after that, the temporal lobe will recover the alt part of the insula, like this, this, and this. At 32, it will be in the middle. Half the way at 28, a quarter of the way at 26, and square at 24. This, this, this. You may say it's difficult. You may have another indicator between 26 and 28. You see the difference here for sure, but look here. There is one more sulcus, which is the superior temporal sulcus, which appear around 27. So with all this, you can have an idea of the maturation of the brain with a precision of 10 days, as we published in 2008. So this is open angle at 22, 45 angle at 22, 25 at 22, 24, 90, and the covering of the posterior part of the insula. So this is the case. It's the first ultrasound, and we get this biometry, head circumference 28, abdominal 26, femur 26, and the question is it a patient at 26 with a huge head, or a patient at 28 with a IUGR, what do you think? 26, for sure it's 26. And you can look also, if you are very clever, you go a little bit up, and you have the central sulcus, which appear around 26, and this very small depression at 26, which become a bit deeper later in the pregnancy. And you can also look at the DTC, and you know the DTC, or the TCD, sorry, it's 28 or 29 around 26, so you are right, it was 26. And this is very useful, and each day I do that, I put my probe, and I just see if the maturation of the brain is consistent with the gestational age. In some cases, these patients was referred for us for isolated ventriculomegaly. But if you look at the Sylvian fissure, right away you say it's not isolated. You see? Because this is wide open, it's open like a 20 weeks pregnancy. So this is not consistent with something normal. And we did an MR, and on MR, you see you have exactly the same shape. But you see also that the cortical ribbon is undulated, and this is a diffuse polymicrogyria. So I think it's very simple, very basic. You may have listened to that many times, but I think it's very important to repeat, repeat, and repeat, because it's the routine. So we'll do that on the live scan. You see you are on cavum symptom pellicidi, and here you are on the CSP. Okay. What do you think? Is 24 degrees, or it is square, or is it in the middle? I came back. You have a precision of 1 week. So you will say 24. I repeat. We go. You know, where is the pointer? It should be 24 degrees at 22, square at 24, and the insula will be recovered by the temporal lobe after that. So here, you think it's 45 degrees, or orthogonal, or between the two? I think for me it's between the two, and the patient is at 23. So for us, it's good to know that she's at 23 for sure. And just to show you something, you see, when I do my scanning, I look at you, but I don't have to look at the screen or to the patient. And you see, the midline is really orthogonal. Okay. So when I do that, I have just to turn my hand like this, and if I do that, I will be on the corner view. Okay. So you have my hand here. Okay. So you see on my hand, this is axial. I just have to turn like this coronal, and there is two, in fact, wall of the house. One here, one here. And if you want to put the roof is here. The roof should be here. And if the roof is here, you see, it's very simple to obtain up. I have to push a little bit because she's not. So we'll do the sagittal plane after that. So just to remind you that the midline should be orthogonal to the beam. And when you scan from top to down, you see the midline stay in the midline. And this is very important, and the midline is at equal distance from the two vaults. And if you want to know where you have to measure, we say that it's important to have two landmarks. Here you see clearly that you have, where the, okay, thank you. This is V shape with subarctal spaces, which is the ambient cisterna. And here, this is here the fornix column, and just above you have the cavum septum pellucidum. Okay, and you see that the cavum septum pellucidum, the AP diameter should be larger than the transverse diameter, because if the AP diameter is shorter than the transverse, you may deal with callosal degenesis. So now you know that you have to measure the ventricle, and you know that you have a small depression, and I will show you here. This is up. In that case, it's not worthwhile to measure the ventricle because it's very very thin. But if you have to measure, you see that the depression is here. So you measure from here to here. Okay. If you have any question, feel free to ask. So you see that you see ventricle. It can be interesting to see also this. What is this? You see one line and one line. Is the third ventricle. And between the third ventricle and the fourth ventricle, there is the aqueduct. And you see how clearly you see the aqueduct. You see this, the lumen of the aqueduct here, you see? And in fact, we can do that in an orthogonal view to show you the aqueduct. And you see the aqueduct, it's going from the third ventricle, and here you have the lumen of the aqueduct. Okay? So now we can go very far here. There is no sulcus, and this is the central sulcus which appear around 26, and we are 23. There is a smooth cortex at this level, which is completely normal. But you know, I think for me it's very important to do that in a perfect axial plane. You see, it's like a CT scan. And when we do MR, we do all this with series of axial plane. If I give you this, we'll say, no, it's not a good MR. But why? When we are scanning, we are not doing exactly the same thing. If we are precise with MR, we should be precise with ultrasound. You see that in that case, you don't see the proximal hemisphere. Sometimes it can be useful to see this hemisphere. And you can do this. I will try to do that for you. Okay, here you see the hemisphere. So this can be interesting. You see, you are completely oblique. So I was, if you see my hand, I was like that, and I will push my probe close to the belly of the patient, and I can have a look at the hemisphere, the proximal hemisphere. It's not to measure because I'm completely oblique, but it can be, in fact, very interesting to look that the ventricular wall is smooth, that there is no ecologic contents within the ventricle, which can suggest that there is intraventricular hemorrhage, that there is no cyst here. In CMV, there can be cyst. So this is a useful view when you want to have an idea of the integrity of the proximal hemisphere. You see, in that case, the subarchal space are really large, and because of that, you see something which is not always seen. What that and that? You know, there is two around structure. I will show you this. You see? It's a chiasma, yes, it's a chiasma, and you see the two optic nerves coming here and joining at the chiasma. You see? How fine is the image, that case? So we may, on the axial plane, do you have any question? feel free to ask. And there is a, you see for the posterior fossa, you see clearly the fourth ventricle, which is here. Here. You see the echogenicity of the vermis, and you see the two hemispheres. And you see that the fourth ventricle, the AP diameter is superior to the transverse diameter. If the AP diameter is longer than the transverse diameter, and you have hexadactyly, what's your diagnosis? So, yes. Joubert syndrome, yes. So each time you have polydactyly or echogenic kinase, look at the fourth ventricle to be sure that it's normal. If you see that the AP diameter is longer than the transverse diameter, you have elongation of the peduncle in a case of molar tooth sign, and it's Joubert syndrome. Okay? So if you have something wrong with the posterior fossa, you have to go to a sagittal view. So this is, it's a little bit tricky in that case, because but you see here. Okay, this is the vermis. Okay, you see a perfect vermis, and you may see also this, which is the aqueduct. Okay, and you have ici here the pons, the bulb of the pons. You have the tentorium, which is here. And if you look, the echogenicity of the vermis is greater than the hemispheres. If you go at 26 from one side to the other, and there is no echogenicity of the vermis, and the TCD is a little bit decreased, what's your diagnosis? You go from one side, hypoechoic, no echogenicity in the middle, and the TCD is a little bit decreased. Yes, rhombocephalosynapses, yes. You are very clever. Okay, so just ask me a question, I can continue like that.
If you suspect that the proximal ventricle is enlarged, how you measure it?
This is a good question, because it's very difficult to be. You can do it on coronal view. You can try to do a coronal, but you see, in that case, it will be difficult to do a coronal view. Even if I try like that, I cannot turn the baby. I can try to have a look like this. I know that I'm a little bit oblique. Okay, so if you know that you are oblique, you know that you will increase the measurements. If you are below 10 millimeters, you be sure that there is no problem. The fact is, when you are dealing with maybe there is a ventriculomegaly in the proximal hemisphere, you may do that to have a look and to be sure. But when you do that, you do an axial and oblique view. So in that case, you are not orthogonal, but you are in fact oblique. So in many cases, when some very good guys want to be sure that there is no ventriculomegaly, they try to see the ventricle, do that, yes, I see the ventricle, yes, I see the ventricle, and it's a borderline ventriculomegaly. But it's just, in fact, a false image because of oblique image. Okay. How many time? I can move to the other patients, maybe. If you want, I can move because I don't want to press too much for the midline, and we can continue with the midline with the other patients. Yes. Okay. Thank you so much. I will change. Thank you. So same question. You don't know the gestational age, and we'll try to have a quick look at the Sylvian fissure. Thank you so much. Up. Okay. Alors, you see, it can be tricky. It's here, this one. This is the insula, middle of the insula. Here, all the way. And if you look carefully here, I will try. You begin to see this. You see the very small depression. So at the way, maybe a little bit. So at the way it's 28, a quarter of the way 26. The small depression appear around 27, and she's between 26 and 27. So you see, you don't need to be too precise, but if it's fit for you with 1 week or one and a half, it will be perfect. When there is a delay of 2 weeks, I begin to be of concern about cortical disorders of delay of the maturation. Okay, you see that you see clearly the fourth ventricle here. You see also the optic chiasma here and the optic nerve, and we have to have a look at the midline. I try to have a good. Okay. Not too bad. This is better. But you see, according to the way of scanning, you can have a good genu of the corpus callosum. Up. Okay, you see the vermis, clearly the vermis. You have the corpus callosum, but I want just to see the most anterior part of the corpus callosum, because here you see the genu, which is here, and you see the splenium. So but we are not an orthogonal, but we try to do my best for you. Sometimes it's a real life, so. You see how far I am with my probe in the belly of the patient. Up. Yes, it's better. Yeah. You see here that you see all part of the corpus callosum. You see the rostrum, the genu, the body, and the rostrum, the genu, the body, and the splenium. And when you measure it, you know around 22, it will be 22, and this is okay. So and at 32, it will be 39, 40. So this is a good measurement for a patient at 26. Okay. To be sure that you are really in the middle, you should have the vermis and the nasal bone. So I'm not completely perfect, but almost. Okay. This is okay. And here you see clearly the cavum septum pellucidum here, and here the cavum vergae. Here you see the brainstem. And if we put yes my focal to the brainstem, okay, you see the vermis, and you see that the brainstem is a little bit tricky to analyze, because the anterior part of the brainstem here the pons is more echogenic than the posterior brow. So to have a good measurements of the brainstem using ultrasound, it may be very tricky, and we don't have this with MR. So I prefer to measure the brainstem on my MR compared to ultrasound. because I do all the measurements on ultrasound except for the brainstem, which is more difficult to get with ultrasound due to, you see here, you see clearly that the bones here is more echogenic. And if you have to measure, it's difficult to know if I have to go from here to that. So I prefer to measure with MR. Okay, but to measure the vermis high, it's easy. Okay. So any question? Up. Here, if we go up, you see there is this small depression, which is here, around 26, which is the central sulcus. So if you look at the brain, you are sure that the maturation, if you look now at the TCD 26, it should be 29, and we'll measure it. This one. Okay. Right. Okay, 29. Okay, so with that, if you have a corpus callosum agenesis and you want to be sure it's isolated, you have to be sure that the maturation of the brain is in fact consistent with the gestational age, and this is the case here. Okay. What else you want to know? You see the foliation clearly here, and I don't know why, but when I have to measure the TCD late in the pregnancy, I found that it was easier to see on the coronal view than on axial view. And you see here clearly the foliation. You see the foliation also here. The foliation is transverse. There is some pathologies, especially in CMV infection. You have degenesis of the foliation, with foliation which is in fact not horizontal but vertical, and it leads to irregular aspect of the border of the hemispheres. Okay. You know that what is named from Chile describe the posterior complex. You know the anterior complex. We speak about the anterior complex, which is I haven't shown you the anterior complex. It's here. You see. Can you magnify a little bit? This one? Okay. Okay. Perfect. Here, the cavum septum pellucidum, the genu. Here, the pericallosal, which is difficult to see, and the anatomical fissure. We'll do that here. Maybe the anchor is more visible here. Okay. And you can do that also in coronal view. And in coronal view, it's sometimes more evident. You see that you see the cavum septum pellucidum here. You have here the fibers of the corpus callosum, and here the anatomic fissure with the pericallosal sulcus. Okay, so we can go from here to here, and it can be interesting to do that. If you cannot do a sagittal view, you can do a coronal view, just to be sure that your corpus callosum is well identified. But in that case, you cannot measure the length of the corpus callosum. But in routine, it's not useful to measure the length. Okay. No question. You see at that time that
Dr. Guibaud?
Yes?
Could you please show us how can you measure the posterior fossa landmarks in sagittal plane in the suspicion of Blake's pouch? Okay.
So when there is a Blake's pouch cyst, I will try to be sure that my vermis is complete or not. So this is, yes, it's too bad, but this is better. You see, when you are not strictly on the vermis, it's very easy to see because it's less echogenic. Here, I'm sure that I'm on the vermis. And what I want to know is to be sure that the height of the vermis is good. I know that 28, it should be 16, so we will be between around 14 or 15. Okay, and it's okay. We have a good vermis for this age. The main concern is when there is a cyst and the big exposed cyst, sometimes there is, in fact, compression of the vermis. And in that case, sometimes the eye could be just decreased because of the mass effect. So in that case, it can be interesting to try to have a good view of the vermis and try to see the primary fissure, which is a little bit tricky to see in that case. But here you see the primary fissure, which is which is here. You see this fissure? This is the primary fissure. I will show you maybe better. Yeah, it's better here because I think she's here. Up, sorry, which is here, and so it's a landmark which can be interesting when to be sure that, and you can do that either this way or this way, but by the posterior fontanel, it's easier to have a better visualization of the vermis. Okay. And you see also the first ventricle. You see the chiasma. You see the brainstem. Okay, and you see the aqueduct just above the vermis. Okay. Another question? Don't hesitate to ask.
Mr. Guibaud, is possible to see for the charge syndrome?
Yes.
The frontal sulc, the narinian sulc, and the ear, internal ear.
Yes, it's very difficult to see at this age of pregnancy because at 26 it's not possible. So the inner ear will be, in fact, identified by MR at this age of pregnancy. I'm glad that you asked this question. I'm glad that the patient is 26 because for me it's very difficult to see with ultrasound, and I'm not really sure to see it carefully. So I prefer to have a good view of the internal structures of the ear using MR compared to ultrasound. You can also try to see the olfactory sulci, but in fact, at 26, it's very difficult to see. There will be some indentation here, but there is at 26 there is no way to see. Maybe it will be here, but I don't trust really ultrasound because in short syndrome, you know that in many cases, in most of the cases, you have abnormalities of the olfactory structure, but it can involve the sulci, but the sulci can be normal with absence of bulb, and it can be unilateral or bilateral. So if you have to see the two sulci and the bulbs on the two sides to be sure that all is normal. To do that with MR, with ultrasound, for me it's impossible. So you can see one or two, but you will not see the bulb. And if you see two sulci, you can have a charge without any bulbs, and this is not identified with ultrasound, but only with MR. Okay.
Can you show the measurement for external hydrocephalus?
For
external hydrocephalus.
External hydrocephalus. This is a very good question. In fact, when you have to think about external hydrocephalus, I prefer the term benign familial macrocephaly or benign macrocephaly, because when you say hydrocephalus, for the parents, they go to internet and even it's external hydrocephalus, they will be in concern. So you say when you say benign macrocephaly, it will be better. And in that case, in fact, you are dealing with a baby with a large head, with slight ventriculomegaly, and the main difficulty is to have an idea of how the pericerebral space look in the normal condition. So if you don't have a look each time at the pericerebral spaces, you will never know how they look when it's normal. And you see here, you see the pericerebral spaces, and we have no norms. When we do transfrontalar ultrasound in neonate, we know that we have to measure the pericerebral space at the level of the anteremic fissure. And we have norms for the anteremic fissure space. When it's more than 6 or 7 millimeters, you may deal with benign macrocephaly. But in the prenatal period, we have no norms. So it's a very subjective assessment, is normal or not normal. So when there is no pericerebral spaces, it's very easy. You know that in obstructive hydrocephalus, the pericerebral spaces will disappear. They will increase in two conditions. When there is benign macrocephaly, and they will decrease also with microcephaly when there is a clastic event which reduces the volume of the brain. In CMV, in very severe CMV, you have microcephaly and very large pericerebral spaces. So pericerebral spaces is a very good clue to understand when you have a ventriculomegaly, when you have a macrocephaly or microcephaly, to have an idea of the etiology of the features. So the other way of saying that, when you have macrocephaly and a ventricle around 14 millimeters, is it because of obstruction, or is it because it's a benign macrocephaly? So large head, large ventricle, and you are hesitating between obstruction or benign macrocephaly. Look at the pericerebral spaces. If they look enlarged, you are in the familial benign macrocephaly, which is really rare. But if they are reduced, you are in an obstruction pattern. So this is something which is very interesting to look at, but remain subjective. Okay? Okay, so I think we have to...
Okay, give him a great applause. This was... thank you.